I'd like to do just three things. The first is just to say a couple of preliminary points. The second is just to address this so-called muddle, confusion and humbug and all that jazz in the law. And then I'd like to finish up very briefly by giving you the two reasons why I think we should oppose the legalisation of euthanasia or assisted suicide. So, and I've promised that I won't go over the 10 minutes, so here goes. I'm going to beat you at that, Roger. You went. Three preliminaries. The first is most people know someone who died badly or wildly. Most of us have known someone who longed for the release of an early death. And I imagine that most of us in this room wish for a peaceful death without prolonged suffering, without severe dementia, without dependence. Those things colour our thinking, and indeed they should. My second preliminary. So therefore I think we need to do better at two things. We need to do better at caring for the sick, at caring for the demented, at caring for the dying, radically relieving symptoms and radically responding to existential suffering. And my third preliminary, in the circumstances of 21st century medicine and nursing, in which so many more people die having lost decision-making capacity, we need to do better at reclaiming the Hippocratic commitment to respecting the patient's own decision-making. Advanced care planning, whether by directive or by proxy. So they're my preliminaries. Let me come now to the talk of confusion in the law. I can't even spell the word law, so let me really stick to my area, which is moral philosophy. The flyer for tonight talked about the black hole of ignorance, and Dr. Syme mentioned that kind of thing quite often. In his book, he repeatedly insists that the treatment of pain and other symptoms such as breathlessness in circumstances in which one can foresee that will hasten death must involve an intention to hasten death. To think otherwise, he says, is a remarkable feat of rationalisation. Well, my question is, why are people so muddled? Why, when every doctor knows that the treatment he authorises in order to shrink the cancer will have the side effects such as nausea and vomiting, which he certainly doesn't seek? Why, when every town planner knows that the new roadway he proposes in order to make the traffic flow better will be the site of traffic accidents in which people die, which he certainly doesn't seek? Why, when everyone knows that if you raise the level of education in a country, you will also raise the suicide rate? Why do people still insist that there's no difference between what's intended and what's foreseen? Now, I think there are two explanations. The first explanation is just bad faith. The confusion is opportunistic, it's invented to serve a political purpose, it's feigned confusion, it's all such a mess. We need to change the law, we need to clear things up. That's one explanation. But another explanation is that I think we have here a clash of two ways of reasoning about ethics, both of which, by the way, are forms of objectivism, both of which assume that there are truly moral facts, there's truly some truth of the matter. And I think this is really the deeper explanation of the confusion. So let me set out to you those two approaches to moral reasoning. One says that there are some features of human acts which are wrong-making features. So if an act is properly described as killing, then that's a wrong-making feature. Or if an act is properly described as breaking a promise, that's a wrong-making feature. If an act is properly described as torture, that's a wrong-making feature. And this approach generally adds, don't do the acts which have these wrong-making features. Don't do things that are intrinsically wrong. Don't kill, neither oneself nor others. Don't help people to kill themselves. And note that there various explanations are given of the wrongness of each of those things, the wrongness of killings. For instance, Socrates had one explanation of the wrongness of killing, Kant had another, there are others. Now, on this approach to moral reasoning, this approach to moral reasoning has to answer a question: aren't we sometimes justified in doing good even though we foresee harmful consequences? Aren't we justified in shrinking the cancer even though we foresee the nausea and the vomiting? Aren't we justified in building the road even though we foresee the traffic accidents? Aren't we justified in trying to raise the level of education even though we foresee a rise in the suicide rate? And this approach says, yes, indeed, we are. But we have to pay careful attention to the unintended consequences of our actions to ensure that they don't become morally intolerable. The principle of double effect clarifies that thought. It clarifies that thought for anyone who thinks that he has reason not to kill and reason not to help someone to commit suicide, but may or should relieve suffering in a manner which happens to hasten death. So that's one way of thinking. But the other approach, they don't exhaust the field, but another approach to moral reasoning says there's only one wrong-making feature of actions, that is, to bring about a greater balance of bad over good. So to do something which doesn't relieve suffering. Normally actions have both good and bad consequences and you have to calculate them. So the only wrong-making feature of an action is one which doesn't have the effect of bringing about the relief of suffering. Torture isn't wrong in and of itself, it's wrong only if it brings about a greater balance of bad over good. Same for breaking a promise, same for killing. And the approach is called consequentialism. And you can see that that approach makes no distinction between intended and foreseen consequences. For consequences are the only feature of action that are irrelevant in their moral assessment. Intention doesn't matter, the act itself doesn't matter, context doesn't matter, even motive doesn't matter. Only consequences. And when you add to that view that the only kind of consequence that matters is the satisfaction of preferences or desire, or you could call it the relief of suffering, then you have an approach to moral reasoning which makes the principle of double effect truly, deeply mysterious. I won't try to adjudicate between these two approaches to moral reasoning. My suggestion to you is that the confusion is often explained by a clash between those two ways of thinking. Last thing. Why do I think we ought to oppose the legalisation of euthanasia and assisted suicide? Two reasons, an in practice one and an in principle one. The in practice one is that I think that ultimately legalised physician-assisted suicide would be uncontrollable. In my view, it had moved from assisted suicide in a few hard cases, truly hard cases, to euthanasia in a much wider range of cases. In the Netherlands, they've already moved, with respect to the children, from the voluntary to the non-voluntary. Now, Dr. Syme says that all that he advocates is physician-assisted suicide for the competent patient. But recently, and I've never met Dr. Syme in person before, but we have met in public debate before, and we recently met on the program Australia Talks. And when Dr. Syme was asked what he thought about people who fear becoming demented, this is what he said. At the moment, we are struggling to get legislation for what is a very much simpler problem, and that is the person who does have clearly demonstrable competence and who's perfectly rational. And I don't think that we want to muddy the water in any way with discussions about dementia. Ultimately, if society deems that laws for people who are rational and competent are appropriate, it may well be that society will eventually see that that is perhaps an unfair situation, that people with dementia ought to be considered, and will work out some mechanism for dealing with that. But that, in my opinion, will probably be in 20 or 30 years in the distance. End of quote. That remark illustrates why I think that the legalisation would be uncontrollable, why I think we'd go from the voluntary to the non-voluntary, from the terminally ill to the physically sick, from the physically sick to the depressed and to the lonely and the fearful. The in-principle objection to the legalisation of euthanasia or assisted suicide is, simply put, the inviolability of human life. As the Select Committee of the House of Lords put it, and I'm quoting, "We consider that the law should not make a distinction between mercy killing and other murder. To distinguish between mercy killing and murder would be to cross the line which prohibits any intentional killing, a line which we think it is essential to preserve. Society's prohibition of intentional killing is the cornerstone of law and social relationships." But surely, it might be objected, people can waive their right to life and the law should recognise that waiver. But that objection assumes that the only value that attaches to life is the value that the person whose life it is attaches to it. And it assumes that it's reasonable for a doctor to concur in that negative evaluation. We have reason to reject both those assumptions.
Rather than actually address any of the medical or legal arguments, which people far more competent than I have done tonight, I just wanted to discuss two of the areas that really struck me when I was researching that book, things that shed light not on the sort of adversarial aspects of this debate, which side is right, but maybe throws more light back onto us as a society and the context in which we discuss these things. One is my experience of discussions in the Netherlands, and the other is the issue of palliative care. When I was talking to people in the Netherlands, I quickly realised that it is perhaps not such a clear model for what may or may not be done in Australia, because the values of people in Holland, given that we share a Western heritage, it was so surprisingly different to ours. The terms in which they discussed the issue of voluntary euthanasia, both the legislators, the doctors, on both sides, were surprisingly different. Three things, and also the debate was much cooler, which is quite interesting, much less adversarial. And three characteristics of Dutch society, I think, informed that. One is their astonishing openness, their tendency to bring everything out into the open and discuss it endlessly, sometimes it seems to foreigners. Bosses and union leaders will stay around the negotiating table forever until some kind of agreement is reached. And I think that's what's made it possible to have the discussion and the resolution of the voluntary euthanasia issue there, when really those moral arguments on each side are actually irreconcilable. I mean, the argument against is based on a moral principle about the act of killing, as Bernadette just discussed. The argument pro is about the rights of the individual to dispose of their own body, to make decisions about life and death for themselves. There is a wall that separates those two things. They cannot be concurrent. This is where the Dutch ability to discuss endlessly came in handy. There's also a historical principle in Holland called, if there are any Dutch people here, I don't think I've got the pronunciation right, gedogen, whereby people make accommodations to the realities of life, even while subscribing to something quite different in theory. And it's how voluntary euthanasia was practically decriminalised long before it was legally decriminalised. And it's how a majority Christian Democrat government managed to pass the eventual law that did so. Secondly, the Dutch still have a deeply personal relationship with their doctors, whom they hold in extraordinary respect, almost reverence. Very old-fashioned idea for us. And the corporatisation of healthcare there really hasn't gained much ground yet. people there told me that this is based in their experience during the Second World War, when Dutch doctors as a body refused to obey the occupation laws, refused to perform sterilisation of Jews, refused, ironically enough, to perform euthanasia on the handicapped, ironically for our discussion, refused to open their records to official scrutiny, and when their licences were revoked, they stopped signing official documents, death certificates, what have you, but continued to care for their patients. And the patients' great faith in their doctors, together with this openness I've just discussed, has made discussion of the issue of death, how are we going to deal with this, to be broached more easily, and the decisions made with less underlying unease than happens here. Thirdly, there is a universal health care system there. It's comprehensive, and nursing care is free. So there are no economic pressures. People do not feel the economic pressure to decide whether they should, get this over with. This is the children's inheritance that I'm squandering here. There is nothing like that goes on over there. And a large majority of Dutch people still die in their own beds, attended by their own doctors. There is not an impersonal situation. I spoke to politicians and medical people who were for and against voluntary euthanasia, as well as ordinary people whose relatives had made use of the law, or who had put in place provisions for making their own decisions when the time came. What surprised me was the conversations I had with, for example, people who were against the legislation. I spoke to Andrew Ruvaert, who was a representative of the Conservative Christian Party, the Christian Uni. He's now the leader, actually. But he was then he was its bioethics spokesperson. He's one of the nicest people I've met, actually. He's very thoughtful, very sincere. He explained why, though the laws had been passed, he had to continue to campaign to have them repealed, or at least limited as far as possible. He said that for him and his colleagues it wasn't a political issue but a deeply moral one. He also believed so strongly in his moral argument that it seemed to me that he just didn't bother to gather every tangential piece of ballast he could. He dismissed the slippery slope argument, for example, which people here, who are against voluntary euthanasia, put great emphasis on. Because he said, the slippery slope argument being that once legislation is passed, the restrictions on it, the limitations slowly get eroded away. But he's just simply shrugged that away and said safeguards can be built in. They can be built in and they can be adhered to. Interestingly, he not once said anything pejorative about the people who believed in voluntary euthanasia. Similarly with a doctor who runs a palliative care hospice, which is very specifically and publicly against voluntary euthanasia, Dr. Zillick, Ben Zillick. Don't get me wrong, he said to me at one point in his argument, my colleagues who believe in this are doing it for the right reasons. They want to help their patients just as I do, but I don't believe it's the right thing. Interestingly, the local hospital has reported a significant decrease in voluntary euthanasia cases since his hospice opened down the road. A similar difference of tone was found amongst people who made use or would make use of the laws to help their relatives or anticipated helping themselves. They spoke more of their responsibilities than of their rights. Here we tend to say it's my right to have this. They talk about the responsibility for their own lives, responsibility for making a morally weighty decision that a doctor should not be expected to make for them, responsibility even for the happiness and security of their loved ones in the long term. Now, interestingly, polling shows that the same number of people, 80%, it's the general figure around the world, approve of the voluntary euthanasia laws in Holland as, say, it should be legalised here. So it's interesting in terms of what is possible politically and in terms of how popular sentiment determines public policy, that there is a clear difference at work here. Mind you, while I was researching my book, I got into lots of casual conversations with people, most of whom immediately said, of course it must be legalised, and referred to some ghastly experience of a wild death that a relative or a friend or something had been through. And yet, because I was looking at both sides of the argument, when I started saying, had you thought about this, had you thought about that, it's extraordinary how quickly people wavered, when you start discussing the idea of the prescriptive force of the law, or when you start talking to them about what terminal sedation means, for example. And when the wider social ramifications were explored, people started saying, maybe it's not that simple, which is quite interesting, I think. Sorry, where am I? The other key thing I wanted to mention was palliative care, which is what I ended up actually passionate about after having done the work on this book. I didn't end up being passionate about one side of the debate or the other, but about the importance of palliative care, which should be an integral part of any discussion about voluntary euthanasia, as Dr. Syme, I think, has put great weight on in his book. In many discussions with professional palliative care people, the phrase existential pain came up a lot. It's the social and psychological dimensions of dying that often gets left out of the debate. People on both sides agree that only in about 5% of cases is physical pain not manageable. Now, 5% is terrifying enough, mind you, but 95% of the cases something can be done. What is more intractable is how people deal with disfigurement, loss of dignity, loss of the ordinary pleasures in life, the heightened tensions in dysfunctional family relationships, the anger and frustration and depression that these things can cause. And this is what good palliative care deals with after the pharmaceutical dimensions have been achieved. And there is so much more that can be done today, so much more, as pioneering practice shows. Better pain management, more people able to stay in their own homes, more counselling, and some kind of return to that tradition of being with people, sitting by them, right to the end. But that requires not only much more focused funding, but a complete reorganisation of the priorities and the infrastructure towards the wider social structure and away from the pointy end of medicine. In a way, those years, well, I've actually just said that time I was immersed in this. It was palliative care that really I became passionate about. Firstly, it's very difficult not to have enormous admiration for the people who have devoted their lives to it. But philosophically, it made me realise that whichever side of the debate one is on, the availability of palliative care, as good as it gets, is absolutely crucial. Because if we continue to deny people the ability to end their lives when they can no longer bear it, we must stand by them and relieve their suffering, physical and existential, in every way possible. But if the time comes when we decide as a society that some form of euthanasia, voluntary euthanasia, is made legal, we must ensure that people really have exhausted every possible avenue for alleviating their suffering before they choose death over life, which is the most terrifying prospect, the most terrifying decision anyone could ever make. Thank you.